Hi guys, this is a re-recorded version of a talk on death, dying and palliative care that I did to the FIY1s in Sunderland in June 2020, which had to be redone, I'm afraid, because of technical difficulties. It's all a work in progress. Hopefully people find this useful. Please let us know in the comments, or if you're at South Tyneside of Sunderland, please send us an email, which you should have received earlier, to let us know if there's anything else we can do differently. Hopefully this is something that that works, and that's something that you all find useful. If you've got any more suggestions for topics or any comments, please let me know. So this is the social distance learning teaching on dying in palliative care. My name is Michael Sen. I'm an ST5 in elderly care. You can follow us at co_videos. The link is on the screen. Send a message below in the comments, or you can send an email to us if you are a member of South Tyneside and Sunderland Trust. We're going to talk a bit about palliative care briefly, talking about dying in the care of the dying document and medications in palliative care. Palliative care is a broad subject. I'm not going to go into too much detail. I'm going to do a lot of talks about palliative emergencies, which I'm not really going to cover here. Palliative care is about supporting a patient's symptoms in attempting to improve or maintain quality of life. And it's non-curative, though may lengthen lifespan, and actually the goal is looking after a patient's symptoms. It's an ethical discussion because obviously some patient may find it affront to not continue treatment, but actually it doesn't mean a patient is dying immediately, but should prompt discussions regarding advanced care planning. Who should be involved? Well, definitely the patient, if they're able to, if they've got capacity. Family and friends, if the patient wishes. GP should be informed. At some point, the parent team is nice to be involved with as well, and then obviously other teams such as Macmillan teams and social workers may need to be involved, particularly in talking about discharge. Questions to consider when thinking about palliative care: what is the expected trajectory? The classical question obviously being, how long do I have to live, doctor? But this may be phrased in a way that you can look at it in a subjective way. If someone's deteriorated over a few days, it might be reasonable to presume they'll deteriorate further in a few days. If they're deteriorated over a few years, then that's likely to be a longer process. Similarly, symptoms, it's probably best to try and explain the symptoms that you might be worried about. So, for example, talking about cord compression symptoms, so loss of anal tone symptoms, so problems passing water, or problems with fecal incontinence, and obviously reduced sensation and reduced strength in the muscles, particularly the legs and lower down, but these can obviously happen everywhere. So it's worthwhile explaining for these to make sure patients are aware of signs. It's quite common to see patients on chemotherapy to be told to check their temperature should they feel unwell, particularly kind of out for things like neutropenic sepsis. It's also reasonable for the patients to ask what is going to go on, what do they want to know, and some patients have a different viewpoint on this. A lot of patients, though, do actually want to know on it, and there's been good evidence that show that patients want to know more than we might think. And then also it's worthwhile exploring, does the patient have any thoughts regarding their treatment or their care or their last days? Some people have very strong thoughts, and it's quite clear when you speak to some relatives or patients that they've actually thought about this a long time, and then it's quite clear also that some don't. And there's obviously a spectrum in between. But examples of palliative care can be quite broad. Palliative radiotherapy to make metastatic compression to maintain mobility. This is a palliative emergency, and actually is one of the ways you can get an early MRI scan by presenting with these symptoms to rule out. Stenting of bowel cancer occasionally happens, though is less common, and that can be done to reduce diarrhea symptoms, to try and improve bowel flow. Similarly, prophylactic plating of metastatic femurs. The orthopods are normally quite keen to do this, as it can prevent fractures in the future, which is obviously a bit more complicated. However, it doesn't have to just involve surgery. Patients can be on a continuous syringe driver for a long time for pain or nausea often, and patients can be given long-term oxygen therapy and Oromorph for breathlessness. So why do we talk about these? The reason why is that we can actually give our patients the power, empower them to help with their treatment, to maintain their decisions in the future. And one of the formal ways of doing this is through the deciding right forms. These are decision aids to support patients in their future care. Unfortunately, they're very uncommonly filled in, but can be useful. And the advanced decision to refuse treatment, ADRT, is legally binding, but is rarely filled out in my experience. In fact, I've never seen one in 10 years of being a doctor. The DNACPR form is probably the most common example of this, and is obviously up and down in the press, particularly recently with the COVID-19 pandemic. To be clear, it is a medical decision. CPR is classed as medical treatment, so you therefore cannot request CPR. You can decline CPR, and this form has a box which you can say you can. A patient with capacity is refusing consent for CPR, but you can't request it. Therefore, the signatures on the bottom, and this again, people get a bit het up about this, are for the doctors. The patients and the next of kin do not need to sign this, and people get very worried about it. And it's a medical decision, so the family don't have to agree with this, but we have to explain it. And that actually has been brought through in case law, particularly involving the Human Rights Act, a couple of cases in Cambridge, and also one locally, where it is expected now that unless, and this is very rare scenarios, which you would struggle to argue that this is the case, that unless the patient gets very distressed about these discussions, and it's appropriate to put one in, all DNRs must be discussed with the patient and the next of kin. The reason why this has become more relevant recently is that there was a GP practice in Wales that apparently sent out a letter blanketly discussing about DNACPRs in their patients, which did not involve a discussion, and this obviously hit the BBC website, as you can see here with this link. An ADRT, an advanced decision to refuse treatment, is very uncommonly filled in, but is a stronger way of expressing your views. Again, you cannot request treatment, you cannot request resuscitation, and similarly, you cannot request illegal things such as euthanasia, but you can also decline treatment in this. And this is normally something that is legally binding, unless it's written in a way that doesn't work. You can see there's lots of spaces here, so it's in specific treatments in specific circumstances. So obviously, if this isn't written well, there is room for this to be reviewed. The emergency healthcare plan is more commonly filled in, but has no legal binding, and is actually normally filled in almost as more of an instruction list. You can write it, and I have written it in ways that can help with expressing the patient's ways. But there are sections here, and you can see here, out of hours contacts, particularly relatives. These can sometimes obviously not be contacted, or patients and relatives can change minds. So therefore, how useful this is, it's not clear. And I have to admit, in general terms, it's not hugely useful. If you have a well-written one, it can actually be very useful to understand patients' wishes before a deterioration and if they lose capacity. Why these are important is that patients often really want control over their illness, and that's often very difficult to give in medicine. But actually, declining treatment is actually a strong way of gaining control, albeit in a way that ultimately will lead to the patient's death. Albeit everyone dies, but in a way that perhaps would be quicker than if they had undergone more active treatment. This is an example of a lady I saw when I've been a doctor. She was admitted with neutropenic sepsis following chemotherapy for metastatic breast cancer. Had multiple admissions with neutropenic sepsis. And for those who don't know, neutropenic sepsis is when all the white cells of your body become ineffective. And in fact, the chemotherapy, because it kills off all the fast-growing cells, which includes white cells, it kills off the white cells. So therefore, you struggle to fight infections. And neutropenic sepsis is another emergency. The patient always felt awful after the chemotherapy, and she said she would not wish chemotherapy on her worst enemy. And actually, this is a person that you can approach these conversations about advanced decisions and what they want in the future. Okay, I've talked about palliative care here. We're going to have hopefully some future talks about palliative care emergencies in future times. But we're going to move on to dying here. And dying is obviously a very emotive subject, understandably so. Signs of dying, symptoms of dying can often include a number of things. Bedbound, semi or unconscious patients and unable to eat and drink. These are common symptoms and are often used to help diagnose death. But they do need a diagnosis that could lead to death. Symptoms such as bedbound, semi-unconscious, unable to eat and drink can also occur in other conditions such as hypoactive delirium or hypoglycemia, or traumatic subdural bleeding or other type of intracranial events, and therefore you need a diagnosis that could lead to these symptoms before you kind of think the patient is dying. If you're an FIY doctor and you think someone is dying, call for help from senior colleagues immediately, and also think about looking for a DNACPR at this point in time. If you're unable to find one, then you need to put out the 2222 call, which is the universal cardiac arrest call in England, and therefore that calls that out. I think speaking as a medical registrar, if someone was peri-arrest and you put out a call, I wouldn't be unhappy with it, and I think that's a totally appropriate thing to do. If you think someone is dying, have a chat with your seniors. As an FIY1, you are unlikely to be put in a position where you're going to be making decisions about this, but your senior colleagues will certainly be able to help to guide really the two ways of going forward: continuing active treatment or palliation. If you think someone is dying, these are considerations to take into, and maybe at your stage you can look into these and think about how your patients in front of you would react to these. You can think about the diagnosis. Has a person got a diagnosis that could lead to them dying? You could think about the care and dying document, which I'll talk about in a moment. Talk about the preferred place of death, which will cover observations and investigations. Are they worthwhile continuing? Eating, drinking, and fluids. We'll talk about that later. Medicines, which ones are we going to continue? Which ones are we going to stop? Thinking about common symptoms such as pain or nausea, and thinking about the patient's spirituality. As in all situations, do ask if you're unsure. Involve the team. Palliative care teams universally, in my experience, have all been very helpful, but also a lot of nurses I've worked with are very helpful and very experienced with this. We will, of course, as your senior doctors, be engaged. If you rang us up and say, I think I've got a patient who's dying, I think a patient who's on palliative care needs a bit of help, we're always happy to help. So please don't be afraid to pick up the phone or walk around and find us, okay? The major thing is that we would be worried about if you started making plans without discussion with the patient and next of kin, because really palliation, this time of life, really should involve the patient and the next of kin if the patient wants them to be involved. This is the care of the dying document, care for the dying patient, it's sometimes called. The document was introduced and has been introduced gradually as a replacement for the Liverpool care pathway, which covered a lot of the things that are covered in the care for the dying patient, but politically was not the way forward. It got a lot of stick in the press because patients were probably being inappropriately managed on it. It's not a pathway. Patients can come off it. People do improve. It is embarrassing for us, but it's in some ways, it is in many ways a nice thing if a patient gets better after we think that they were dying. It goes with them on discharge, so it goes to the community to be continued there. And it summarises plans for all discussed eventualities. So that's the reason why it's important to discuss all the things I mentioned before. What I would say is at your level, I would consider referral to the palliative care team when starting this. And how to complete it, really, it talks through all those questions I'm going through. I'd like to think that if I'm doing a ward round or a review of the patient and I think I'm going to palliate the patient and start the care of the dying document, I would like to make sure that I've covered all these points here, really, because these make it easier to fill in the document, whilst also talking through the patients and the family to make sure that we're all on the same page about this. Preferred place of death is a very emotive subject. A lot of patients really prefer to go to home or prefer to stay in hospital. I think the hospital thing, we should take that as a compliment. Home can be sometimes difficult, as many patients have care needs that may not be able to be fulfilled at home. A lot of families prefer hospices or hospitals as well. Hospices, I've heard great things about them. They often have access to chefs and occasionally access to alcohol and other nice things to keep the patients engaged. So it's perhaps less of a formal process than a hospital, but these are very popular and often they struggle to accommodate patients at short notice. Nursing care homes sometimes are therefore more practical, particularly nursing homes with nurses on site who can administer palliative drugs and also with increased clinical skills. Talking about nutrition in fluids, and this was one of the major complaints about the Liverpool care pathway, as it was perceived that people were starving whilst on it. This is probably not true, but in general, it's useful to be clear to families and patients that if they are hungry or thirsty and they're able to eat and drink, then by all means they can eat and drink as they're able to. The difficult thing happens is if they're unable to eat and drink, whether because they're unconscious or other reasons, and in which case that discussions about non-oral routes such as intravenous subcutaneous fluids should be happening. Personally, I try to avoid fluids because subcut fluids even can worsen upper respiratory secretions and maybe prolong death without necessarily improving symptoms. There's some discussion that patients lose their thirst when they're dying due to a combination of consciousness and possibly a mild delirium or severe delirium going on due to concurrent illness. So I tend to have that discussion with families and express that. And I have to admit, I've had very few arguments with that. Okay, guys, so I'm going to move on to medicines in palliative care. I'm going to talk about medicines that we can stop and also medicines that we can start. As with always, at an early stage at FIY1 level, you can discuss with seniors, a pharmacist or palliative care team if you're unsure about what's going on. I tend to continue usual critical meds, and these are the long list, and I'll come up to these later, but consider alternative routes if no oral is not available. For example, in Parkinson's disease, for patients on levodopa, you can consider a reticotine patch. There's a calculation with this. Normally, I would do this in discussion with the pharmacist, though I've done this enough that I know of useful sites that have conversion rates to. Epilepsy is another one that is complicated, partly because without giving oral medication or IV medication, you're reduced to using a subcutaneous continuous high-dose midazolam driver, and that actually sedates patients to the point where they may be unconscious, and that's not ideal. I'll talk about those later. The main ones to think about stopping are the patients on prognostic medications. These are the obvious ones, such as statins, and this gives me a little bit of joy in stopping these medications, since we know that some patients don't feel the benefit of taking tablets that they're only going to feel in 10 years' time. You can prescribe medications even if someone's not on the care of the dying document in anticipation, which are called anticipatory meds. And this is often a set that I'll talk about later. I would check your local guidelines to see what are being used commonly. And you can also speak to your seniors. The main symptoms I'm covering today are pain, nausea, vomiting, breathlessness, and respiratory secretions and agitation. There are other guides, especially in the NECN guidance, which is linked to at the end of this presentation, which are not covered here, these are really quite long things to read about. And to be honest, I would still refer to the NECN guidance to guide my patients. Here's a rough list of medications that you can consider continuing and stopping. I would definitely continue anti-epileptic meds if I'm able to, ideally through the oral route. Similarly, Parkinson's meds, dementia drugs, particularly donepezil and the cholinesterase inhibitors, and antipsychotics. Symptomatic meds I tend to continue as well, so analgesia orally if I'm able to, inhalers, and then other medications like, for example, furosemide, which may help symptoms of breathlessness and heart failure, and anti-anginals if patients are getting recurrent angina. You can consider stopping other medications. We talked about statins. Anticoagulants in a patient who is dying who's not able to take an oral route is definitely worth stopping, as you could argue that a PE is an end stage causing syndrome anyway. Antihypertensive, again, are similarly perhaps not useful if someone is unconscious or unable to take medications. I've referred to it briefly already. It's Northern England Clinical Network's Palliative and End-of-Life Care Guidelines for symptom control. And this is not just for cancer patients, this is for all patients. This is one of the few documents that I would carry around with me if I hadn't put it on my phone already, but it's a really useful guide. All flowcharts available and pictures available here are from the North East Clinical Network. Starting off with pain, as with all symptoms I'm going to talk about here, you treat the patient individually, review the cause, treat the underlying cause if you can, but in more complicated patients or unconscious patients, you may have to resort to the syringe drivers and subcutaneous medications we're talking about. However, if someone's able to take tablets and they've got, for example, neuropathic pain, you could certainly try something like pregabalin or gabapentin, and similarly, if they have and able to tolerate NSAIDs and they have joint pain, then you can consider an NSAID in that situation as appropriate. As with everything when it comes to prescribing, review the current treatment. Do the patients find it beneficial? If they do, grand, continue it. Is it ineffective? Well, you can either increase the dose or you can reduce the dose and stop it. Think about which one you want to do and talk to the patients about this. Consider side effects. A lot of painkillers, for example, tramadol, can cause confusion. Morphine tablets, all the opioids can cause confusion. Constipation, amitriptyline can cause confusion and constipation. And all of these are unfortunately side effects which are more prevalent in patients who are dying due to their illness. Pain has got these lovely flow charts. Continue oral meds if able to. Not everyone is able to. Continue patches regardless. This is really because the medication continues to work even if you take off the patch. And it actually doesn't really affect the conversion rates in the long run. If they're on oral opioids, convert these to subcut morphine. And in the Palliative End-of-Life Care Guidelines, there are really nice tables which you can use to convert between them. For example, amongst fentanyl, oxycodone, oxynorm. In patients with normal renal function, subcut morphine is the first line. Alfentanil is used currently if the eGFR is less than 30. Syringe drivers are a really good way to give continuous medications. They're useful for background pain and trying to reduce the need for patients to ask for treatment in patients who will not necessarily be able to. If you're in pain, considering adding the used PRN medications into regular drivers. For example, if they're on 10 milligrams over 24 hours and they're using 2 times 2.5, then the total dose over 24 hours they're using is therefore 15 milligrams. So then the next time you draw up, you could give them 15 milligrams, and that would hopefully prevent them needing the PRNs. Normally, the PRN is calculated as a sixth of the driver dose. So, for example, if someone's on 30 milligrams over 24 hours, then you would give 5 milligrams PRN. Nausea and vomiting is unfortunately a very common symptom in a dying patient, partly because of the underlying illness, but also because of the medication we're giving. Opioids can cause significant nausea. And treat the underlying cause. Unlike for pain, there's no nice flow chart, but that's partly because they're focusing on treatment of the underlying cause. Cyclizine is useful for chemical cause, and that's partly why most guidelines start off with cyclizine. Metoclopramide is useful for gastric motility, though avoid it in Parkinson's disease. It is a dopamine antagonist, so it can cause problems. And also, you can cause problems in complete bowel obstruction and is ineffective. Ondansetron is perhaps used overly because it's recently had a price drop. It sounds a bit shameless, but it's true. And it perhaps only should be used in chemotherapy in post-op patients because it's very constipating. So that's something to be aware of if you're given ondansetron. Dexamethasone is the only other one I would normally use regularly, and that's partly because it reduces edema in general, so it's more of a treatment, but it helps reduce nausea, and particularly in patients with brain metastases and also bowel cancer, so it reduces edema and it helps with reducing the size of mass. Breathlessness is unfortunately a commonly symptom, increasingly more so because of COVID-19. As before, treat the underlying cause as appropriate, and you may consider giving IV antibiotics for these patients if they're already on it or continuing the ongoing dose. Consider checking oxygen saturations, and this is one of the few situations where I might continue observations, and that's really because then I can titrate up oxygen, and I would normally not use nasal prongs. Consider subcut morphine and alfentanil. In patients who still have an oxygen requirement and wish to go to another place after hospital, you can get very rapid installation of home oxygen, including piped in oxygen, for a patient who is dying. So that is an option as well. Thinking about respiratory secretions, these are quite distressing symptoms, and we're normally talking about upper respiratory symptoms where people are talking about drooling or a wet cough. Consider stopping fluids. As I said before, it can worsen secretions, but obviously discuss with patient and family and colleagues first. And consider stopping humidified oxygen. Hyoscine is commonly used. I find butabromide to be less sedating, and that's probably true, but it depends where you are, which people use. Some people also use glycopyrronium, which is also on the guidelines. That's thought to have a less cardiac issue, and some people also struggle a bit with hyoscine. Agitation is a common side effect, often due to medication, often due to end-of-life illness, and the real aspect here I think you should focus on is treating the underlying cause if you're able to. If a patient's in pain, I tend to give them painkillers first rather than starting a midazolam driver, because treating the pain is more likely to treat the underlying agitation. Family and nursing teams can help, though obviously this is labour intensive, and some people do feel under a lot of pressure if you ask them to stay and to help. So it's worthwhile running it by them and discussing. If these fail, I tend to try midazolam. It is very sedating, as I've mentioned before, and you can give it continuously. The COVID-19 guidelines from NHS England suggest using haloperidol for delirium. Though again, that's not a great drug in Parkinson's patients. Other symptom scenarios I talked about before briefly. Detailed guidance is available on the in a lot of areas. I tend to treat if symptomatic, so they've got sweatiness or polydipsia, and you might want to consider stopping medications, but again, it's a case-by-case basis. Epilepsy, I would continue IV medications here, and I might consider putting in cannulas, though it's a bit of a case-by-case basis. Phenytoin, levetiracetam or Keppra, and sodium valproate are all available in IV preparations. Consider a 20 to 30 milligram 24-hour midazolam driver if there's no other option, no. Massive catastrophic bleed is definitely something I would want a senior to be involved with. This can happen in, for example, upper GI bleed and hemoptysis, and really should be planned for before. If someone's got a large fungating lung cancer that is invading their central structures, such as their aorta or their esophagus, then this should be normally known about due to the ready access of CTs, and should be planned for if able to. There are some areas that people will give 10 milligrams of subcutaneous midazolam as a sedative, really to help the patient in their last final moments, assuming this is a terminal event. And some people use blue towels or black towels to hide up any blood. Well, it sounds morbid, but people obviously find it distressing if they are seeing towels with lots of blood, as most of them are white. COVID-19 guidelines I've touched on recently. Obviously, the main symptoms of cough, shortness of breath and fever. Fever can be treated with intravenous or PR paracetamol. Ibuprofen can be given orally. Diclofenac can also be given rectally. But these may not be appropriate in patients with asthma. Symptoms of cough can be helped with simple linctus and morphine syrup, and sometimes taking some water in orally. These may help in the conscious patients. There's been entire guidelines written, which has been linked into the back. I'll link it into the description. At Sunderland, if you're using V6, if you search for dying on the prescribing set, then you come up with this, the care of dying and the renal set. This is a complete set. This makes it easy to prescribe, particularly anticipatory medications. You can see here it's cyclotine by default, and water for injection, which is particularly useful for discharging patients, as this is used to make up the solution. And similarly, searching for syringe driver with any word, you come up with this. They tend to use an Alara syringe pump, and obviously when discharging patients, they'll need to have a pump in place on discharge. In the additive medicine section here, you can see there's some drop-down menus where you can add the drugs that you want to add, and you can change them as you need be, and you don't need to start again. You just change the medications and the drugs as you go along. On a Drug Kardex, and this is perhaps more common though, may change in the future, most community drug cardexes have a box of specific drugs, though community drug cardexes are variable. Some areas are specific palliative care cardexes, which has the name of the common drugs written in already. Some of them just have a standard Kardex. I've struggled to find a standard one. It's actually quite hard to find a generic one online. In terms of a general tips, you can either put it in the continuous infusion box, if that exists. More commonly, I tend to put it on the regular medications with a kind of arrow around the times to indicate that this is a continuous thing. And I tend to write the word continuous in the indications as well. Okay, that's where we are. So in summary, for palliative care and the dying patients, involve patients where possible at all times. DNR does not stop any other treatment and is a medical decision. Palliative care does not mean the patient is dying immediately, though may prompt advanced decisions about future care. Treat the underlying cause when looking at symptoms, and if you're unsure, ask for help. We're always around to help. Hi guys, thanks for listening to the talk on death, dying and palliative care. As noted before, this does not supersede any national local guidelines that you may read, and obviously the Northern Clinical Network guidance is really the Bible to look at this for where we're working in the north of England. If you have any comments, comment either below, message me on Twitter at co_videos, or you can always email me if you're at the South Tynes and Sunderland Trust. Hopefully we'll continue these talks. Please let us know in the comments or in email if you have any other talks that you wish me to go through, or if you have any questions about what I've said, anything that's not clear. All the best, guys. Stay safe.